Good afternoon, everybody, and welcome to this SHOT Meet the Experts webinar, which today is on the avoidable, delayed and undertransfused report category and chapter. The webinar will include a 30-minute presentation, followed by a question and answer session, and then a feedback poll at the end. Your microphone has been muted for the duration of the webinar. As you may have heard, the webinar is being recorded, so we can host it afterwards for those who can't attend. There's no chat facility during the webinar, so if you do have any questions, please write them in the Q&A box and we'll endeavour to answer them during the session. As it's a Meet the Expert session, your questions are very welcomed and will help to enrich the session. We've enabled captioning from the back end of Zoom, so if you wish to turn this off, you can do so from the toolbar and that will hide captioning. So I'm going to introduce the speakers now. We have Dr. Paula Bolton-Maggs, who is a consultant retired haematologist, former SHOT medical director, honorary senior lecturer, Faculty of Biology, Medicine and Health at the University of Manchester, UK, on the SHOT ADU Working Expert Group as well. We have Dr. Josephine McCulloch, who is consultant clinical scientist at NHSBT and Bart's NHS Trust and part of the SHOT ADU Working Expert Group as well. And finally, Dr. Catherine Booth, who is a consultant haematologist at NHSBT and Bart's NHS Health Trust, Associate Medical Director for RCI and Genomics, and Clinical Lead for the NCA of Blood Transfusion, and also part of the SHOT ADU Working Group. So without further ado, we'll go to Kath, who is our first speaker this morning.
Thanks, Vicky. So there's been a couple of events in the last year that have really heightened our awareness of the need to avoid avoidable transfusions. So first of all, the infected blood inquiry, a useful reminder that though blood transfusion is very safe, we can't eliminate all risks. And then the blood shortages, which are, again, a useful reminder that blood is not an infinite resource and we really do need to use it wisely. So what SHOT means by an avoidable transfusion is where a transfusion has gone ahead with an appropriately matched component that's safe for transfusion, but the original decision leading to that transfusion was flawed. And because we should be reassessing our patients after every individual unit transfused before we go on to transfuse another, if you have a patient who received multiple units where only one was appropriate, then we'd count that as an avoidable transfusion rather than an overtransfusion, because whole of those subsequent units were avoidable. So SHOT have been collecting these sort of data in some form or another since around about 2000. First of all, as part of the incorrect blood component transfuse section, and then in their own dedicated chapter since 2008. And the nomenclature we have now was adopted in 2012, where we moved away from inappropriate and unnecessary, which sounds a bit pejorative, to avoidable. And as you can see here, we have fairly consistent numbers of reports, around about 100 to 120 each year. Now, we know that this is just a tip of the iceberg in terms of avoidable transfusions. So if you look systematically at blood transfusions via audit, for example, you'll see that a far higher proportion of transfusions are potentially could have been avoided, or there was an alternative. So what we're really seeking to do here is to learn from the cases that are submitted to us, and to kind of share the knowledge that we gain from them. So in the last couple of years, we've tried to make a kind of logical classification for avoidable transfusions, because as you can imagine, this category captures a wide variety of different errors with different causes. And this classification tries to structure things in a way that also identifies the types of staff members who might be involved. So you can really target the kind of interventions you're putting in place. So first of all, we've got flawed decision. So often sitting with a clinician. Then decision made on inaccurate results. Again, this might be a lookup error from a clinician, or it could be based on a laboratory issue. We see failures to respond to a change in circumstances. So this is often a problem with communication between clinicians and nurses administering blood. So, for example, the plan's changed and that hasn't been relayed, or an operation's been cancelled. And very occasionally, we see a transfusion necessitated by an error earlier in the patient's clinical treatment. We can see transfusion without decisions. This is where there's no prescription or authorization written, but a transfusion goes ahead, often related to errors in the step at the administration step. And then finally, appropriate decision in appropriate component. So this is specifically relates to avoidable use of group O. And this is a really complex set of pathways involving clinicians, laboratory, porters, and all the systems that link them. And as you can see from a 2023 summary, the three top kind of reporting groups we see are the flawed decision based on inaccurate results, and the avoidable use of group O. So I'm going to give a few examples in those categories. So first of all, our flawed decision. So this can be giving a transfusion outside of the kind of recommended guidelines, giving multiple units without review, transfusions for a stable patient with hematinic deficiency, or transfusions given to patients who are bleeding, but actually turned out are not really bleeding enough to warrant transfusion. So here's a sad but all too common type of report. So this was a lady in her 40s with a long history of menorrhagia who was mildly symptomatic with a hemoglobin of 69 and profound iron deficiency, really low ferritin. And she was authorized and transfused 4 units of red cells. She did have an interim hemoglobin check after the 3rd unit, but nobody checked that result before proceeding to give the 4th. And even after 3, her hemoglobin had been 105. And she wasn't given any iron. And the reporter reflected that the doctors on this unit really didn't have a good understanding of how to treat anemia apart from with transfusion. And though there had been a suggestion about having an anemia clinic, there wasn't funding available. So next big category, decision based on inaccurate results. So this can be issues like platelet clumping, erroneous results from point of care, so either an incorrect result or reading the wrong result from the printout, hemodilute samples, using an old result, or using another patient's results, either because of a lookup error or there's been a wrong blood in tube for the full blood count sample. So here's an example from our reports. A patient in the emergency department had a low hemoglobin, 55, and that was phoned through as an emergency by the lab. Now, unfortunately, there were 2 patients in the department with very similar names, and the result was attributed to the wrong patient. So patient B, who had a completely normal hemoglobin, was given a 2-unit blood transfusion, whereas poor patient A, who really needed a transfusion, sat for a good number of hours without receiving anything. So you can see how easily it can happen. The third category I'll go into a little bit of detail on, the avoidable use of group O. So you can, as I said, lots of different professionals and systems involved here. So it may be that there's no valid sample because none was sent, or it's been rejected because of mislabeling. There could be a laboratory delay in processing that sample. Often we see that there's actually group-specific blood available, but it isn't collected either because it hasn't been communicated to the clinical area it's ready, or there's some problem with remote fridges or collecting the correct unit. And we see quite often that there seems to be a lack of understanding about when Group O should be used, that it really is just a stopgap until you can get properly matched blood for your patient. And often the barrier is kind of communication between the various different people involved. So here's a kind of classic example, a patient with GI bleeding who was hemodynamically unstable and anemic, so appropriate for an emergency transfusion, and 2 units of emergency Group O were issued. And at the same time, a transfusion sample was taken. And the first unit got rushed through STAT, and the lab rushed and processed the group and screen sample and had cross-matched blood available within an hour. The second unit of blood that's already gone to the close to the clinical area wasn't started till 2 hours after the till another hour after the first and was given really slowly. So potentially by that time, there was group-specific blood available. So there's issues here about the kind of the communication of that from the lab and about the clinical team understanding that this group O was only a stopgap. So what do we do? How do we avoid these avoidable transfusions? Now, diverse group, so diverse range of solutions, but education is a really important bedrock. That needs to start at the undergraduate level, and it needs to include doctors, nurses, biomedical scientists, and you need to be repeating that frequently in kind of imaginative, bite-sized packets that will really engage with people. So we really need to be creative as transfusion teams. But that's never going to be enough. So how can we employ kind of digital and electronic solutions to help us? Can we integrate computerized decision support? So pop-ups remind people or give them help in making their decisions. Can we integrate things into our electronic prescribing that pull through results, for example? And can we empower other people in the pathway? So our laboratory, our nursing staff, and our patients to question the need for transfusion, to ask if there's an alternative. And then it's important to have really robust processes in the lab. For example, for how do you deal with a result that looks erroneous or a funny low platelet count? And then is our major hemorrhage protocol fit for purpose? Does it include how we're going to communicate that availability of group-specific blood? So I just wanted to, as a last thing, to flag a couple of useful sources of resources. So the patient blood management section of the Hospital and Science website has a host of resources. So there's e-learning modules about anemia and about appropriate blood use in major hemorrhage. There are toolkits, particularly around group O or platelets, for example. There's a blood components app, which take you through the kind of indications for different blood components. And linked to that, just to flag on the National Blood Transfusion Committee website, if you go to the next page, the indication codes have just been updated this year and just released. So do check those out and download the newest version. And there's also good resources there, for example, around appropriate use of ONEG and the types of component to have in your major hemorrhage blood. So thank you very much. I'll pass you on to the next part of our subcategory.
Thanks, Kath. So I'm going to talk to you about the delayed chapter. So let's start with the definition. So SHOT defines delays in transfusion is where a transfusion or a blood component was clinically indicated but was not undertaken, or non-availability of a blood component led to a significant delay. And this can result in patient harm, a delayed admission or admission to a ward, or result in a patient having to come back for a transfusion on another occasion. So what were this year's key SHOT messages on the delayed chapter? So again, similar messages as previous years. Poor communication at multiple points during the patient's care is common, and this exacerbates delays. Delays in the recognition of bleeding increase morbidity and mortality. Low blood pressure should alert clinicians to consider major hemorrhage. Major hemorrhage protocols are not activated or when indicated or not correctly followed. Staff issues contribute to delayed transfusions. And then finally, a lack of knowledge and awareness of correct procedures contributes to delays in blood transfusions as well. So the recommendations from this year's report, that activation of major hemorrhage should be simple and standardized to avoid issues with hospital-specific procedures. And with regards to this, one of the main things that we were trying to focus on was the activation. So the 2222, or however major hemorrhage is activated, it should be standardized within regions and in hospitals to make sure that people who are moving from organization to organization are familiar with how to activate a major hemorrhage. So hospitals should review their major hemorrhage protocol and test them with drills and simulations to ensure they're fit for purpose. And these should cover all steps in the process from the end to end, and must include all staff groups. And this is really important because often laboratory staff are missed out of the major hemorrhage protocols, and yet they are a vital part of the whole process. Major hemorrhage protocols should be followed by a debrief with everyone involved, that's including the laboratory, to identify what went well and what could be improved. Transfusion professionals should work closely with higher education institutes to ensure that courses they are offering are fit for purpose and ensure all staff are equipped with the skills and knowledge they require to deliver safe transfusions. And this should hopefully reduce the burden on hospital laboratories when it comes to training staff, if you've got staff coming out of those higher education institutes ready to work. So you should all be familiar with this graph. The number of delays in transfusion reported to SHOT has increased again this year. So we're talking 212 cases when compared to the previous year of 205. There were 9 deaths reported to the delays chapter. More than half of these deaths were associated with delays in urgent or emergency transfusions. And there were 12 cases that resulted in major morbidity. And again, most of these cases that resulted in major morbidity were again due to delays in urgent or emergency transfusions and major hemorrhage situations. So delays associated with major hemorrhage were again a common area that was identified in this year's report. We've highlighted a total of 50 out of the total that were associated with major hemorrhage incidents. So errors are usually multifaceted. There's not ordinarily just one reason behind it, but communication and incorrect activation of the major hemorrhage protocol remain key issues contributing to delays in transfusion when it comes to major hemorrhage. And this has been consistent over the past 5 years. Other common themes include delays in decision-making and missing vital steps in the transfusion process due to lack of knowledge, training, and poor staffing levels. So laboratory errors also contributed to a large number of delays in the 2023 report, and there was a total of 56 laboratory errors. And this includes hospital transfusion laboratories as well as the blood services. Key themes identified were lack of knowledge and training of staff and failure to effectively communicate. So again, we're seeing the same common themes identified throughout the chapter, and I'd be very keen to get feedback and information from people if they've been able to introduce some effective training that has increased communication in certain circumstances such as major hemorrhage. Okay, so let's have a look at some illustrative cases then. These 2 that I'm going to talk you through are to do with laboratory errors specifically. But you'll see that this one also overlies with major hemorrhage as well. So we've got a printer failure that caused a delay in transfusion. So major hemorrhage protocol was activated for a patient suffering from a GI bleed. There was a delay in blood components being issued as the printer failed to print the labels for the bags. So the BMS did not realise that the printer had run out of labels and tried to reprint. They then contacted a senior member of staff at home for advice, and then the printer was reloaded, and then the labels were then misaligned. So this resulted in a delay of 15 minutes. Now, it might not seem like a long time, but in an urgent and emergency setting, it can feel like a lifetime and can have a huge impact on patient outcome. And in this circumstance, what happened was that the BMS didn't realise that there was a backup or didn't use the backup system to print the labels, and therefore they weren't printed in a timely manner. So this just shows an example of sort of training and processes within the laboratory that have resulted in a delay here that could have potentially been avoided. The next case. So this is one looking at a blood service issue. So the incorrect red cell units were sent to the hospital, results in a delayed transfusion. So samples were sent from a hospital transfusion laboratory to a blood service reference lab for further testing and cross-matching of red cell units. The reference lab completed the testing, but sent the blood components to the wrong hospital. and this resulted in a 2-hour delay in treatment. So a 2-hour delay, depending on the situation, can mean that a patient may be delayed in their treatment, so they're spending a lot longer in the hospital waiting around. It could mean that they have to come back for the next day, so their treatment has been delayed, or potentially another opportunity in the coming weeks. But in an urgent situation, 2 hours can mean that the patient would be transfused with alternative components, and this could increase the risk of potential harm to that patient. So it's really important that sort of basic checks, sort of who the patient is, positive patient identification, and identifying where these units need to go are really important steps that can hopefully help prevent future delays. Next slide. So these are the recommended resources that we put in the chapter. These are accessible online. So if anyone wants to have a look at these, then they're there for you to view. And I will hand over to Paula.
Thank you very much. As you see, over and under transfusion have been reported over 12 years to have 263 cases. Next. How do we define this? Well, it's a dose inappropriate for the patient's needs, excluding those that result in TACO, but also resulting in a hemoglobin or platelet level that's outside the target range. So some of the avoidable transfusions also result in these factors, and then they're included in this group, but there has been some overlap in past years. Infusion pump errors leading to over or under transfusion are important. And they may be reported as handling and storage errors if there aren't any clinical consequences. Thanks. Next, please. So a key feature here is inappropriate volumes transfused for the patient's weight, mainly in children, but also in low body weight adults, and I'll come back to that. And then we've picked up problems with blood component support and major hemorrhage, where the patients have either got too much or too little in relation to their dynamic and changing needs. We've had a couple of cases of major hemorrhage in children where the clinicians are unfamiliar with major hemorrhage in that setting, and then there have been delays and difficulties in over and under transfusion. However, a common reason for undertransfusion is failure, particularly to give a full adult dose of FFP, where a patient's been prescribed a litre or 4 bags and has only received 1. I've mentioned the problems with major hemorrhage when it's difficult to estimate how much has been lost. And again, more incidents are reported in children because of miscalculation of the number of the amount of red cells needed. Next. So this just shows you, if you look at the top line, you can see that 89% of the overtransfusion cases were in children, far more than compared with adults, and that's because of the factors that I've already mentioned. We have had deaths related to both over and under transfusion and major morbidity. Fortunately, a small number, but it's important to get the quantity right. Next. So this is just a summary of some errors in pediatrics, a lot of prescribing errors because the doctors didn't know how to do it. Errors with infusion rates are relatively common. Wrong calculations. We had patients where they got a 10-fold factor out because they were prescribing in the wrong way. And it's important that the components are prescribed in volumes related to weight, and not that they receive more than the standard dose for an adult. So clinical staff who prescribe blood for pediatric patients should not do so unless they've been trained properly in weight-based prescribing. And it's very much a recurring theme that errors are made by doctors that are not normally working in pediatrics and maybe just doing a shift. Next. So another issue is who's in charge of the patient. And this was a particularly interesting one. An elderly patient with a hematological disease was transfused every 2 weeks without reviewing the hemoglobin levels that were measured every time before the transfusion. And the hemoglobin was eventually more than 200 grams per litre, and the patient had iron overload. And part of the problem was who was in charge. The patient was under 2 specialties, and each team thought the other was checking the results. Next. And death related to overtransfusion. Here you see an elderly patient with low body weight, 38 kilograms, presenting with a rectal bleed, and then received 3 units, which was too much for that patient. The post-transfusion hemoglobin was 195, and despite venesection, the patient basically had a stroke and died from the complications related to that. Next. Another illustration, it's very difficult to estimate how much blood is needed or given, if you like, when somebody's got very serious bleeding. And here was a man with a ruptured aortic aneurysm who proceeded to surgery and received more than 3 litres. And the post-operative hemoglobin was 202 grams per litre. This overtransfusion could be avoided by regular checking on point-of-care machines during the very complicated procedure. And he died later the same day, and they reckoned that this was possibly related to the overtransfusion. Next. So there are resources. I won't dwell on those, as I need to pass on to the next topic, which is prothrombin complex concentrates incidents. Thanks. We're collecting those mainly in relation to delays or inappropriate transfusion since 2014, not allergic reactions. Next. So most cases are reported in very elderly patients, and you can see the median age of the ones we've had is 85 years, and they need anticoagulant reversal for bleeding episodes. And of course, more elderly patients are on anticoagulants now than they used to be. When there is a serious problem, such as an intracranial hemorrhage, it's important that the anticoagulant reversal takes place within an hour. Otherwise, the patient is put at risk of expanding bleed and death. Many cases relate to a lack of knowledge about where the PCC is or indeed how to infuse it. This shows you the data, 129 cases, and you can see that 71 were delays in giving the product. Next. So here are the common features of delay: lack of, first of all, ordering and prescribing, lack of knowledge, challenges with guessing the INR, particularly if the patient needs to be weighed, and they're not well enough to get onto a scales. Then there have been a number of cases where there was unnecessarily referral to a consultant hematologist who perhaps didn't answer the phone quickly enough. Laboratory release can be impacted if you don't have enough stock, which has happened and sometimes have to be obtained from another hospital. And then, as I've mentioned, lack of understanding of the importance of giving it or how to reconstitute it and how it has to be given fairly rapidly. Next. So we could reduce delays by having a robust, rapid process, consider access to emergency dose in the emergency department, and that was a recommendation some years ago. I'm strongly in favour of considering an initial fixed dose regime, because then the patient can get the dose, follow it up with an INR to assess need for more, and it gets rid of all the other factors about trying to find the weight and calculating the dose. It should certainly be given immediately before a head scan and before the patient's transferred. There have been some huge delays related to those two factors. Next. The emergency department should ensure they have a protocol. As I've mentioned, a standardized single dose is recommended, and every hospital should regularly audit the timeliness and appropriateness of their use of PCC. Next. So here's some examples. A patient on warfarin with a head injury had a 4-hour delay while the patient was moved between departments and the prescription was lost. Secondly, following a head injury in a patient who had atrial fibrillation and anticoagulants, the infusion was set at completely the wrong rate, 1 ml per hour instead of 1 ml per minute. And a man in his 80s with suspected intracranial hemorrhage had delayed administration because each vial was collected separately from the transfusion laboratory rather than all collected together. So you can see some immediate potential solutions to problems of that sort. Next. Then I was a bit surprised to discover there was a problem because of misunderstanding about the product names. And of course, Octaplas and Octaplex, both marketed by the same firm, and the names are similar. So if people are unfamiliar, they could make this sort of mistake. And here it was made in an elderly man with GI bleeding, where Octaplas was requested verbally when what they wanted was Octaplex. And so there was a delay. Next. So there are a number of resources available, and there are guidelines, and that concludes my presentation. Thank you very much.
And thank you very much to our 3 speakers for very informative presentations. We have had some Q&A come through, and I'll start asking those questions now. Please feel free to put your questions in the Q&A tab at the bottom of your screen so we can ask the questions that you're putting through. This is a great opportunity to discuss these things with our experts. Our first question is from somebody called Yana, who's asking, where can I find more information on immunization after transfusion of emergency RHD positive red blood cells to an RHD negative patient in the shot annual reports?
I'm not sure whether it's in the SHOT annual report, but I know that some years ago I looked the data up and it was rather reassuring that it doesn't happen very often. And so I'm sure in one of the reports we've alluded to that in a paragraph. And if you do a literature search on the subject, you'll find out that it's not as big a risk as you're led to believe. That doesn't mean you should do it, though.
Yeah, I was going to say, so there have been systematic reviews, because there's been, particularly at the moment, where there's been the group O neg shortage and consideration of whether pre-hospital teams might carry O pos instead of O neg. There's been updated systematic reviews around the general risk of transfusing O pos to an O neg recipient. SHOT would only collect those cases if it was done in error. So if you've have a woman of childbearing potential who should have received O neg as an emergency and received O pos, that would be SHOT reportable, but not a formation of anti-D in a D negative man who got stabbed and was given a life-saving O pos transfusion as an appropriate clinical decision.
I think that Mark Yeaser from the States has written on the subject of this business of getting, I think he's looked at several thousand O neg O pos transfusions. So if you look him up by name, YAZER, you might be able to find the references.
Thank you.
Super, thank you. Shall I move on to question number 2? So this one's from an anonymous. What more can be done to address reoccurring cases of ADU, especially the use of avoidable O's? So what can we do to address those reoccurring issues?
It's really challenging. The fact that they're recurring shows that these are really complex systems, and single solutions are clearly not going to fix everything, or would have done it long since. And this is why SHOT are, look what learning points we can pull from reports every year. So I think, locally really examining your process, and I think certainly a recurring theme we see is that how does your clinical team know that the group specific is available? Often our major hemorrhage protocols emphasize the need for the clinical team to communicate with the laboratory, but where's that bi-directional communication? How do you establish that? And getting that really well embedded. And we've certainly seen, recent years, significant knowledge gaps in clinical teams around when Group O should be used, and often a feeling that, oh, the patient is bleeding, therefore they need Group O. And we even had examples of group-specific blood being delivered to the bedside, the portrait collected from the laboratory for that patient, and being turned away because it wasn't the emergency Group O. So any centre is going to need a multi-pronged approach, and maybe if you know you've got particular challenges at your centre, look at your own reports, your own examples, and see where in the which multiple points probably in the process you need to be able to step in to help.
I think it's really helpful that if hospitals audit their own use. I remember I did it when I was working at Alder Hey Children's Hospital. I encouraged the surgeons to audit their ordering and use of blood. And when we presented the data, the senior surgeon said, "Do we really do that?" So I think it's quite a helpful way of reflecting on your practice to see what you actually do, because then you'll find the points in the system where you can make corrections.
Thank you both.
Thank you.
Next question is, how can technology or decision support tools be used to minimize avoidable transfusions?
I think you get me again. So then I think this is a really an area with lots of potential, and there's a kind of hierarchy of interventions, because you might imagine that these could be very complex and costly, and yes, some of them may be. So formal kind of computerized decision support systems where information pops up relevant to your patient's results and the transfusion you're about to authorize are quite complex to introduce, lots of technology needed, but there may be sort of simpler things you could do in the meantime. So, for example, many places are introducing electronic prescribing. Even something as simple as pulling through the patient's results into a form that you're producing can help protect from reading the wrong result, for example, looking at an old result from a year ago. So really take the advantage, take the opportunity. If you've got a new system being introduced, make sure you're in there with your ICT, straight up being the ones involved in the design. Often easier than introducing something later. But even there may be simpler still, just making that information available, making it in bite-sized chunks in ways that people can see it, that are visual or other multimedia. We're being really creative about how we present this information to people when that it sort of pops up at really timely points. So it needn't necessarily then be the most complex AI-driven system. That's digital presentations can really help us here, I think.
Super, thank you. I'll move on to the next question. Oh, it's just dropped off my screen. So the next one is, how many major hemorrhage drills a year is appropriate in your opinion?
I think it's difficult to get even one. I don't know what Joan.
Controversial, Paul.
A lot of hospitals don't do them because they don't think it's necessary. Or they don't have, I mean, there's a staffing issue and time, because if you're going to do it, you need to do it with the whole team, because unless you do it with the whole team, you don't find out which are the weak links. I don't know what the others think.
I think it is challenging, and I think it entirely depends on the centre that you're working at, as that suppose depends on how frequently major hemorrhage protocols are activated, how many issues you have with your major hemorrhage protocol. Because if it's infrequent, you probably want to maybe test it a little bit more, keeping people familiar with the process, compared to a sort of maybe a bigger centre where they have several major hemorrhages. They're testing their process with the actual major hemorrhage that's happening, and then reviewing based on incidents. But like Paula said, it is challenging because you've got to ideally get everybody in the room together. But I think you'll find that a lot of people are testing major hemorrhage protocols in isolation. So it's definitely worth reaching out in the HTCs, for example, to the obstetric teams. They run quite frequent simulations, and seeing if we can get the laboratory involved in existing programs of work. But I personally, what I've done before is try to run at least 2 a year, if not more. But it entirely depends on your sort of situation and the hospital that you're working in. That's my opinion.
Excellent,
Certainly,
thank you, Jo.
to review all the activations that you have is important. It's like, the audit of those, because I think people learn a lot by what went well and what didn't go well in the ones that have already occurred.
Great, thank you. And we have a question here from Alex, who's asking, how do we go about empowering laboratory staff, and what does this look like in practice?
Again, it will depend on your local setup, and I've seen it done extremely successfully, and there are lots of challenges with that. You need a really robust support system so the laboratory staff don't feel like they're on their own, and certainly that we're not asking them to make any clinical decisions. But having some really clear criteria for the scientist to question. And I think the other, to make that acceptable, it's really important that is launched kind of with your clinical teams. So for example, if you're having a focus on single unit transfusions, you need to do your piece of work with them, with your educating your clinical teams, supporting them with your electronic tools if you have such a thing. And part of that launching to say, okay, to help you with this, the laboratory are going to ask you, if you are trying to order 2, they're going to suggest, can you order 1 and review? And then that's giving the scientific team the backup, the authority that they need to make that acceptable. And then they need to be very well supported by clinicians, so particularly hematologists, where it's complex decision making, so that they're not trying to police, they're trying to advise, and they're trying to be able to signpost the clinicians to other sources of support. So I've certainly seen worked in hospitals where it has been done really successfully, and it's because it's been kind of becomes expected by the clinical areas that this will happen, not kind of pounced upon them and they start thinking, oh, who is this who's this tech in the lab who's trying to tell me what to do.
There was a very good presentation to a shop meeting a few years ago where whoever presented it presented a conversation between people in the clinical area and a person in the laboratory. And one of the things that they were illustrating was that sometimes the language that the two people are using is not understood by the other. And that goes back to the things that we've seen so many times with delayed transfusion about communication. So I think it's really important. And certainly one of the hospitals where I worked, there was a member of the laboratory staff present at every weekly meeting of the hematology team so that they could understand what was happening to the patients and relay that back to the lab staff, who were very interested to know about the people for whom they were providing the components, sorry.
Can I
Absolutely.
add to that?
Oh, sorry, Jo,
Sorry,
yeah.
Nikki. So yeah, I think education is really important when it comes to empowering laboratory staff, involving them in clinical cases that are happening, so they can understand the complexities around the decision making and understand that it's not a black and white scenario. So that even though we are trying to empower people to maybe use less or think about using one unit rather than two, it's not always a straightforward decision, and it's more of a suggestion and potentially a prompt. You know, have you thought about this? Have you, rather than no, you can't have the unit because XYZ. So I think education is really important.
Fantastic, thank you. There is an anonymous question. Is the red cell dosage calculator software offered by Bolton? Would it be a useful tool for low body weight patients who need transfusion?
Yes, and I'm sure it's available. Because Sharon Gray's published it in the SHOT report. So I don't know whether it's accessible from SHOT, but it certainly should be.
I believe it's accessible from all NHS sites. And if you
Maybe
look at the TACO FAQ document, there is a link on there that takes you to the red cell calculator. And that is available on the SHOT website under the cumulative data for TACO.
And if you can't find it, absolutely get in touch with the general SHOT email and we can point you in that right direction. Yeah.
Maybe a clever person can find it and post it in the chat, or the question and answer challenge for the team.
Thanks, Paula. I'll move on to the next question, which is also by an anonymous attendee. What criteria should be used to determine if a transfusion is truly necessary and volumes are appropriate?
Well, I jump in before Kath, but I'm sure she'll pick this up. I mean, it depends on the circumstances. But one of the frustrating things, for example, is when a patient with folate deficiency receives 3 units of red cells when what they need is folate. So I feel strongly about checking hematinics, and I find it disappointing that people don't recognize from the full blood count the clues that it might be folate or B12 deficiency, macrocytosis, a reduced platelet count as well, and instead they ladle in the red cells when what the poor patient needs is vitamins.
Yeah, absolutely. And the mantra I spout to everybody, we treat patients and not numbers. So there's no kind of hemoglobin cutoff that's going to say a transfusion isn't appropriate. An appropriate transfusion is one that follows a detailed clinical assessment of that patient, the reversible causes of anemia, the discussion with that patient about their wishes around transfusion, a weighing up of the risks and benefits, and then giving the minimum amount to achieve your goal. And so having that goal in mind before you give the transfusion, and a goal is not increasing the numbers by X% number of points. The goal is some outcome in that patient. So yeah, it's that easy. There's your appropriate transfusion. And unless you, so for example, if you're doing an audit of appropriate transfusions in a trust, you can never do it based on numbers. It would require a clinician to laboriously go through every transfusion and look at all those circumstances, which is why we do need to support our clinicians to make appropriate decisions. But then remember we're hoping that they've applied their clinical judgment, and yeah, we give them the pointers and the resources to consider all those other factors.
The National Clinical Audit Programme has been very useful in helping look at all these topics, and that's available on the blood. I've forgotten the site, but have a look at the national audits that have been done. They're tremendously informative. And the audit of blood transfusion medical patients showed a lot of it was not necessary.
And we know that 2/3 of our blood goes to medical and not kind of surgical or trauma indications. And often in those scenarios, you have got time to think, is the other kind of key message. You don't need to run in with the red stuff. Your patient's probably not collapsing in front of you. So take that bit of time. It's
surprisingly how well fit children and adults can tolerate a slowly falling hemoglobin. And certainly, for example, toddlers, children of like 2 years of age who become iron deficient over a long period of time because all they're having is milk, can be running around the ward with a hemoglobin of 30 and not showing very much in the way of symptoms. And that is not a panic job for transfusion. It's a bring on the iron and educate the parents.
Yeah, absolutely. Our bodies are remarkably designed and have confidence in all the physiological processes that are going on unbeknownst to you, behind the scenes, that are ensuring that the oxygen is still getting to your tissues, even though the hemoglobin is low.
There was, I forget which year it was, there was an adult who came in with pancytopenia, hemoglobin 40, platelet count 15, and a low white count. And the junior doctor who saw that patient put out a major hemorrhage call. And that was a patient who had folate deficiency, who was asymptomatic in the bed, actually.
Yeah, patients are not numbers.
Following on from that, there's a question from Nicola. Is there a risk that computerized clinical decision support could contribute to notification blindness? So, and how, if you think that is the case, how do you combat that? Bit of alert fatigue.
Yeah, great question. And yes, I don't think we've got a solution. Alert fatigue is a real issue. As we certainly see as a recurrent theme in laboratories around reasons why safety notices and things weren't followed. I confess to doing it myself with the thousands of things that pop up on my clinical system when I open it about some downtime and something else. Is that a reason not to do it at all? The worst thing, if you've got nothing at all at the moment and you introduce something and it catches 1 in 5 inappropriate transfusions, then perhaps you've still done some good. I think using it appropriately and sparingly. So the more things that pop up at an inappropriate time, the more people will just delete them. So having your cutoff set reasonably, maybe not every, don't have it universally, maybe don't have it at every, the hemoglobin is, I don't know, 71 and it fires going, your patient's not got a hemoglobin of less than 70. So yeah, less is maybe more.
I think it's important that we don't forget to think and to look at the patient. We've said this before, haven't we, several times during this. It's useful to have algorithms and guidelines, but guidelines are not rules, and it's very important to see whether that fits the clinical scenario that you're dealing with, and to make sure that you and your staff have adequate education to understand what's going on and not just rely on some computerized algorithm.
I think it's going to be really important moving forward, because this is a really important question, because I think this is where people are looking to move the direction, digitally sort of supporting clinical decision making. And I think it's really important that we are very careful with how we design the systems, and we look at what's already been done? Maybe not in transfusion, but in other disciplines. What are other people doing? How can we adapt from that? And is there any sort of studies that have been done that we can learn about people's behaviours in dealing with these types of situations? So I think, yeah, there needs to be a lot of thought go into the design of these systems.
And there is a systematic review, updated systematic review, hopefully coming out next year from Cochrane Group around evidence supporting computerized decision support tools specifically for transfusion. Probably not too much of a spoiler alert. There have been few very well conducted studies that will give you that kind of robust data. So exactly as Joe says, that's what's going to give us the kind of the confidence to know that these are really effective.
Thank you all. There's a question here from an anonymous attendee. How many hours after a transfusion do we need to recheck the hemoglobin? Does this need to be after every unit? And do we need to repeat this after every transfusion to check for effectiveness of the transfusion?
So unless there is active bleeding, we should be reassessing after each individual unit transfused, unless so that might not be appropriate if your patient's on a chronic transfusion program where your kind of your aims are different. But certainly in your acutely anemic patient, so this is someone who's maybe had surgery, had a bleed, their hemoglobin's dropped, and you just need to support them while they are recovering. First thing is that you must have your clinical goal in mind before you embark on transfusion, because then how do you know if the patient's got better or not? So your assessments, or the most important thing is, how is the patient now? Have they improved clinically enough that a single unit was sufficient? And then the hemoglobin check is just an additional a small part of that, but actually the clinical review is just as important. So you just need to, in terms of time, you just need to leave long enough that transfused blood is kind of equilibrated in the system. So you know, if you're using don't take blood from a line that's been transfused through, but otherwise you could take it 15 minutes after transfusion. You don't need to keep the patient in, make them wait for an hour or anything. But yes, we should be using that as part of our global assessment of the patient.
I wondered whether that question was partly geared towards how often do you need to do it when you've got a major hemorrhage? But unless you are actually monitoring what's happening during a major hemorrhage, you don't know how far you've got.
Mm-hmm.
And that applies just as much to regular coagulation testing. And I don't know what the ideal is. It must depend on the circumstances. But I mean, the shock cases that we've got show that it's possible to both under and overestimate. And in one tragic case, we had a woman who hemorrhaged during childbirth, and they thought they'd caught up with what she'd lost. I think she received 2 units, and then about 5 hours later, she suddenly collapsed and died because actually they hadn't caught up with what she'd lost. So it's a warning about being alert and about, in the acute setting, making sure you're doing the testing enough times to know where you're up to. But I don't think you can make precise rules about that. I'm sure in the major hemorrhage transfusion guidelines, it says monitor these things regularly. But how regularly must depend on the situation that you're actually in.
And the difficulty in a major hemorrhage setting is, if the patient's really actively bleeding, you're always a long way kind of behind in terms of your catch up. So it may be helpful if the patient is stabilizing and you want to making sure you're not going to over transfuse. So if you run your blood gas and it's already telling you you've got a hemoglobin more than 100, okay, you can probably stop for now. But otherwise, the principles of transfusion in a major hemorrhage setting is, again, clinical targets. So has your patient got a blood pressure now? Have they got a palpable radial pulse? But that relies on you also having got the diagnosis of bleeding correct in the first place. We've seen a number of reports related to it, and a patient just comes in sick and maybe hypotensive, and someone assumes, or they've got abdominal pain, someone assumes this is because of bleeding, gives them some blood, and actually they were septic, they had some bowel perforation, they had something else to explain their their clinical presentation, and actually blood transfusion wasn't going to do them any good at all. And we've had a few unnecessary or over transfusions in that sort of setting.
The next question is a very topical question. How can hospitals be prepared to avoid delays during cyber attacks or IT downtime occurs?
Gosh, I suppose planning. That sounds a bit, but yeah, planning for situations like this. I think everyone plans for really good management plans when it comes to sort of blood shortages, because we've been through them. But I think sometimes we forget that actually, and sort of major sort of traumas and mass casualty events, people always have plans for those. I think people forget that IT actually is probably one of our most vulnerable. So we do need to plan for things like that. So there's an over reliance, I suppose, on technology now for valid reasons. But it's about sort of making sure that we've got robust manual systems in place, that people are trained against those contingency plans, and having plans in place that are tested. That would be my sort of main go-to to prevent delays. I know it's not too detailed, but we could go for days talking about the detail of what that planning involves.
I think some of the advice that's going to come out following the recent London cyber attacks is one, for everyone to make sure they've got good business continuity plans, and also that they consider not just a short-term IT downtime. I think that's something that's caught a lot of people out this time, and that actually that you consider, okay, what if it doesn't come back online in a week, 2 weeks, longer even. And something I found really eye-opening, a friend of mine who'd worked in Australia, worked in the emergency department in a hospital in Australia, and they they simulated tested their business continuity plans for IT downtime in real time, in a live environment, in emergency department. So they switched off all of their IT, and they saw how how they could cope with the flow if there was no IT support. And I thought, golly, how refreshing! If only we did that. And perhaps in the unreliable NHS, we just rely on us getting regular practices because the stuff goes down all the time. But yeah, I would love to do a bit of kind of real simulation or real-time testing of our business continuity plans.
Thank you, everybody. I think we've more or less run out of time for questions. So if there's any burning questions still in the Q&A, if those attendees wouldn't mind emailing us to the SHOT, emailing them to the SHOT inbox, and we will forward them on to the experts. I'll now hand over to Vicky to close off the webinar.
Thank you, Karen, and thank you to the speakers for absolutely fascinating talks and for all those engaging questions. I think it's been a really useful webinar. So we're just going to launch a short poll now for all attendees. Your feedback is really, really welcomed. It helps us form these webinars and help us direct our resources in the future. While those poll questions come up, I'd just like to inform you that today's session has been recorded. This will be available on the SHOT website in the coming weeks on the specific Meet the Experts tab on the SHOT website. There's no certificate available from the SHOT team for this session, but if you'd like to record your reflective practice, you can then record this for a CPD activity. We've got one more Meet the Experts session coming up this year. So that's on the 17th of December, and that's on IT that we've touched on slightly today. So you can still register for that on the SHOT website. That's on the Meet the Experts page as well. And as Karen said, if you've got any other burning questions following the webinar, please do send them to us. The email address is shot@nhsbt.nhs.uk. And any questions regarding that or anything else, the team would be happy to answer. So I think we'll leave the poll up for a little bit longer here. I think it's just 7 short questions, and then it is really valued. Helps us, form the sessions. Fabulous. Wonderful. Thank you for joining us today. It's all been great, and it's always good to get together and discuss these things and have the interactive sessions. So thank you very much for attending. I think we'll close the webinar now and see you all at the next session or at the next SHOT webinar. So thank you very much.